high technology world, and we all enjoy the benefits of that, but I wonder sometimes whether we really understand the drawbacks of it. The medical profession is one that traditionally cares for people at a very personal level, and here we see a doctor in a rather old-fashioned way making a home visit, a visit that enables him not only to talk to his patient, but to give some comfort to the patient's family too. Can this sort of personal care continue in our modern world? Today our program looks at the somber problem of caring for the terminally ill. Hello everybody, welcome once again to Issues in Focus.
Alan, have you thought about your own old age and dying?
Well, I try not to think about dying, Peggy. It's a very somber subject, but we have to face it on today's program. I think if I do ever visualize my own death, I try to think of it in very personal terms. And we saw earlier at the very beginning of the program the kind of automated high-technology medicine that we're all used to. I'm very afraid of an impersonal death.
Of course, today, increasing numbers of people are dying in hospitals, not at home.
Yeah, this is a problem, of course. I think most people like me would prefer to die at home if they had the choice.
This chart shows how by 1976 here in Japan, many more people were dying in hospitals than at home.
Does this mean that families are not living up to their traditional responsibility to their older members? Are they foisting that responsibility off onto a rather impersonal medical profession?
Well, yes, maybe, but I think there are many fewer children to look after the aged, as there are more and more old people in this society. Many more women are working, and of course, many more people are living in small urban apartments. There's just not room to take care of a dying person.
Right, this is a problem that involves all kinds of social phenomena. I wonder whether we could also say that I would like to go on living as long as I was assured of a meaningful existence. I think people who die feeling that they've failed, that their life has just come to an automatic end, are rather sad cases.
Well, it's very hard to give meaning to a person who's in pain. But one of the important things is that psychological and spiritual factors often make pain. And we talked with Dr. Kashiwagi at Yodogawa Christian Hospital about just such a problem.
One social worker had a very good relationship with the patient. And this patient said to this social worker that the most important thing for me at this point is not my life, but the most important thing for me is the marriage of my daughter. Before I die, I'd like to just attend the wedding ceremony of my daughter. That was her last hope. So we called her fiancé to the hospital, and we said to him that, you know, your fiancé's mother is dying, and she would like to attend the wedding of you. And he said, okay, let marry a little bit earlier, you know. And we arranged, and 1 month later, the patient could attend to the wedding, ceremony. Oh, she was so pleased. Before that, she was very anxious, she was very fearful, and her facial expression was like this, she was very rigid. But after attending this wedding ceremony, she was so relaxed, she was so happy. And then, interestingly enough, her pain disappeared,
Well, Peggy, we usually think of doctors as people who cure. And in today's program, I think it's important if we bear in mind the two little words cure and care. Earlier, I was talking about the necessity of caring in a traditional and very personal way, both on the part of the medical profession and on the part of patients' families. Now, in the rest of the program, we're going to be talking about the hospice movement. And I wonder, Peggy, whether you could just tell us in a few words what that is.
Well, the hospice movement wants to bring humanized care to the person who is dying. The hospice movement started in the late 1960s in England, and it's spreading all over the world. Here in Japan, too, you find many articles in newspapers, for example, about the hospice idea and people engaged in hospice-related activities.
Hospices are buildings in the same way as hospitals?
No, the hospice is a movement, an idea. Here in Tokyo on September 2nd and 3rd, an international seminar was held about holistic care of patients and their families. Holistic means caring for the whole person. The seminar invited several well-known hospice authorities from overseas to talk about caring for the dying.
All of us fear death. It is part of the survival instinct. We feel uneasy in life-threatening situations. We also feel uneasy in the presence of death. There is therefore a natural...
At the same conference, a Japanese doctor suggested that the Western-based hospice idea should be remodeled to suit a non-Christian culture.
千の言葉を用いて励ますよりも黙って手を握って包み込んであげた方が患者に安らぎを与える場合もあります。また今後作られていくホスピスにおいても日本人のメンタリティを考慮し、家族との密接な連絡あるいは良い意味での身内意識を配慮したケアを考え、そしてシステム化していく。
The audience included doctors, nurses, social workers, and students. We asked a Canadian, Dr. Mount, about the spread of the hospice movement all over the world.
The modern hospice movement started in England, and there have been conferences and hospice activity in that country, in North America, both in Canada and the United States, and also in many parts of the world, in Australia, New Zealand.
Peggy, well, earlier I suggested that we should try and think about these two little words, care and cure. What exactly does hospice care consist in?
Well, let's look at this film, which answers a lot of our questions about the hospice movement and care.
First of all, what exactly does the word hospice mean?
The word hospice comes from the same root word as hospital and hospitality. In Europe, in the Middle Ages, Christian monks ran hospices to take care of pilgrims and travelers.
There again we have the idea of taking care of.
But they took care of the spirit as well as the body.
And that's an important thing to remember. Now, we're looking here at a modern hospice, aren't we? This is a hospice building. Where is this?
In London, it's St. Christopher's Hospice, the first modern facility to be called a hospice, founded in 1967.
In 1967. And the lady who founded it was this lady, I think.
Cecily Saunders, a physician, a social worker. She was one of the first people to use this old term hospice for the hospice movement as we know it now. She was concerned with helping dying patients and their families improve the quality of life at the final moments of living.
And how does this sort of place compare with the ordinary sort of hospital that we are familiar with?
Well, the hospice focuses on holistic care. It's concerned with the spirit as well as the body, and people like Cecily Saunders believe that pain comes from psychological factors like fear and anxiety.
Certainly.
So in a hospice you find touching and caring, bright colors and flowers.
And people instead of machines and medicines.
No, very few machines, in fact.
Do the people who are admitted to hospices such as this know that they are terminally ill, that they're dying?
Yes, I think death is talked about openly and honestly, of course. there are many different individual variations.
What about the families of the people? How involved are they in the treatment that goes on here?
Of course, they're encouraged to visit. Relatives, even grandchildren, are welcome at hospices.
Are visiting hours restricted in the same way as they are at ordinary hospitals?
No, there aren't the same sort of inflexible rules. Drinking alcoholic beverages, doing what you want, all of these things are encouraged. It's the idea of treating the person as an individual.
And also of paying some attention to the person's choice, to what he wants to do, to how he or she wants to spend the last weeks or months of his or her life. What sort of people take part as a hospice team?
Well, although there are doctors and nurses, of course, on the hospice team, there are also many other people providing services and many volunteers.
Are these volunteers people with medical training in the ordinary sense?
Well, they do go through training periods, and there's a lot of staff meeting support for all the people on the team.
But they're mainly people who volunteer to be with the people who are dying. They're not going to cure them in the same way that doctors and nurses would ordinarily try to. They're going to comfort them, to make these last months of their life important to them.
Yes. I think in terms of improving the quality of life, though, it isn't just emotional or talking support. One outstanding idea of the hospice movement is pain control. A specially developed mixture of drugs is used, which helps keep patients, even cancer patients, for example, mentally alert, but pain-free.
Well, I said earlier, when you asked me that very personal question, that I think continuing to live a meaningful existence is important to someone who knows they're dying, and being mentally alert must make a very great difference. If you're lying in bed as a vegetable, that's one thing, but if you can take an active part in what is going on around you, especially if it concerns your own family and friends, that must make a very great difference. Well, now we've been looking at hospice activity in England, and you mentioned that the first modern hospice was opened in England in 1967, the one that was founded by Cicely Saunders. What about America, Peggy? Has the hospice movement caught on there?
Yes, the hospice movement has spread rapidly in the United States. This is the Connecticut Hospice, the first facility called a hospice in America. Every day finds more than 1,000 people, double this facility's capacity, waiting for a bed so they can be admitted. They come from other hospitals or from home in the last stages of their illness, and most live only a few days here at the hospice.
Well, both the English hospice we've seen and this American hospice are buildings, aren't they? They're separate facilities which are called hospices. But actually, this is not always the case, is it?
You're right. The hospice movement is more than just buildings. It's home care, support teams that help families deal with death and dying.
Well, I mentioned that I would prefer to die at home if I had the choice, especially if I could be surrounded by my family, and I expect that would be true of you and most of our viewers too. What does a hospice team do for a patient who wants to be at home rather than in a facility like the ones we've seen?
Well, it actually makes these visits on a daily basis to help the woman in the family with this physical burden of caring for the dying patient.
Well, we've talked about the difference between caring and curing. Peggy, it might be a good idea if we tried to sum up in a few short sentences the difference between the hospitals that we are so familiar with and the hospices that we are introducing today.
I talked with Valerie de Marinis about this difference between hospices and hospitals. She teaches medical ethics at Harvard University, and she's also held seminars on the hospice movement in Kyoto.
When medical equipment and technology is used only for the prolongation of death, that is the time when technology should be removed. Although I must say that there have been several cases whereby when a person has been given the prognosis of 2 months, they've gone into hospice care, and because the care is so good as medical care, they have gone into remission or recovered. So the hospice orientation is not so much around the point of dying, but more holistic care. So that really the ideal of hospice is that that every hospital will more or less reclaim that base, which is historically the orientation of holistic care, but which technology has kind of isolated. Unfortunately, modern-day hospital has evolved into what we call an acute care institution, meaning the orientation is a particular disease diagnosed with a particular history to be expected, with a given prognosis for surgery or treatment, and then release. So the modern-day hospital is a wonderful institution if you are a person who has an illness that is short-term. By the very nature of its definition, then, the acute care hospital offers very little in terms of its orientation to someone who will not get better. Hospitals are really a reflection of modern-day culture, that the dying person is brought to the hospital even though the hospital is not an appropriate place, but the family doesn't want to be reminded of the dying person. And really, it's not so much from a lack of care, but really a lack of knowledge of how to treat, because dying has become so alienated in a culture that stresses youth and productivity. And so in the hospital, with the physicians especially, who are really a reflection of culture, that so not only is it the technological idea of an acute hospital that doesn't have the facilities and treatment for long-term care, but more also the psychological idea that if I can't cure a patient, I'm seen as a failure. So naturally the dying person, for a number of reasons, then practical, psychological, is put more towards the back ward. So it's not wholly an unfeeling attitude, but more it's just an inappropriate place for care. And up until modern times, there really was no appropriate place for care. It really, I think, reflects the philosophy that dying is a part of life, not enemy of life. And that dying people, as all people, are important members of society and not outcasts to be put away in the back wards. I've been using dying person. Hospice would probably take exception to that. That adjective is not what should be given prominence. The dying person is a person, because dying is a natural stage of life. I think really has to be a re-education that begins not so much when someone has the pronouncement that they're going to die in 2 months, but more beginning with children and different, all through the ages in society, to begin facing questions about death and dying. The first way and fundamental way is to begin slowly to let that sacred word out of your mouth. Talk about it with children. Let children go to see grandpa and grandma who's dying. It seems that especially children and old people can get along very well, and they've become so separated with the loss of extended families. So begin very naturally where the opportunity is available.
It sounds from what we've seen and from what Dr. Marinis was saying there that the hospice movement is the magic answer to all the difficulties of dying, Peggy. Can this be so? Do you think as the movement spreads and grows larger, it'll encounter problems and difficulties?
Well, I think there are dangers to the hospice movement, that it'll just become another way of hiding away the dying, of warehousing of the dying, just like the nursing home has its problems in the United States.
So on the personal level and on the institutional level, it's very important to keep this idea of caring and of the patient's choice in the forefront of one's mind, I think. Has the hospice movement made any headway in Japan?
Yes, the first team based on hospice ideals was formed in 1973 at the Yodogawa Christian Hospital. The team leader, Dr. Tetsuo Kashiwagi, has been raising money to build a hospice unit. It's now under construction within the Yodogawa Hospital complex. It will be completed in 1985. This hospice unit or floor will have the warm, home-like atmosphere of American and English hospices, with a sunroom, for example. There will be a kitchen for the patients' families, so that patients can have home-cooked food that they prefer. There will be special consultation rooms, and also tatami rooms for those who prefer a real Japanese-style home-like atmosphere. In terms of the Japanese insurance system, for example, insurance would cover care in the hospice, won't it?
Well, they are going to cover the how do you say, admission fee, for example. They would cover the drug fee, for example. They would cover the examination fee. For example, if I give the painkiller to the dying patient, this painkiller will be covered by insurance. If I examine the patient using chest X-ray, for example, they will cover the chest X-ray. Okay, the whole problem is, if I sit down at the bedside of the patient and listen to the patient for 1 hour, that is very, very important care for the dying patient. Insurance is not going to pay anything. That is a problem. For example, in the United States, if you have a hospice, I think the government decided here lately to give some amount of money to the hospice care as a total. But in Japan, I hope in the future it will be true, but at this point, they do not have any special insurance to the hospice program. In usual hospital, for example, they do not have social worker. Right. They do not have chaplain. But every hospital have doctor and nurses. So at least you can have team consisting of doctors and nurses. So if you can have a weekly basis team conference to the dying patient, you can do that in any kind of hospital in Japan. And actually, they have started this team approach to the dying patient in a couple of hospitals already. I can point out 4 or 5 big hospitals which are doing this team approach to the dying patient. As a matter of fact, this is happening in England especially. As I said before, they have about 40 hospices in England, and the average bed number is 25. That means they have 1,000 dying patients only.
That's a very small
very
number.
Small. But the idea, their hospice care idea is spreading all over the hospitals in England. They have lots of influences. And here in Japan, I think that same thing will happen. In this hospital too, we have team approach, and there are lots of nurses attending from pediatric ward, for example, from OBGYN, from outpatient department. So they are learning what is a hospice care. So in this team, we discuss many things, and sometimes we have lectures, sometimes we have films, sometimes we have slide, presentation. Then this hospice care spirit is spreading gradually to the whole hospital. And I think in the future, if you have a very good hospice as a model, even if it is very small, the spirit of the hospice care is going to spread to the usual hospital, which I'm expecting.
Well, Peggy, my worry listening to all of this and seeing what we've been looking at on the program today has been that as the hospice movement grows and develops, it runs the risk of, again, encouraging families not to take a responsibility for their own elderly. The families may think, well, there's a hospice, there are trained people there are volunteers and doctors and nurses. It's their responsibility, not ours, and that would bring us back to the original problem. But there, Dr. Kashiwagi was talking very reassuringly, I thought, about care at a personal level, and he reminded me of the other rather more old-fashioned doctor that we began the program with, making his home visit. It is reassuring, do you find, that the hospice movement, if it grows and develops in the way that Dr. Kashiwagi supposes it will re-encourage people to think individually about caring?
I think it's important that the modern hospital move back to treating the whole patient, the spirit, the psyche, as well as the body. And if hospices, perhaps facilities, separate facilities themselves, do not particularly spread, if the ideals of the hospice movement can be incorporated into the regular hospital, for example, I think that's very important.
Yes, we've been talking about hospital versus hospice and care versus cure, but we're really talking, as you said earlier, about a whole thing, a spiritual and physical thing, and really we hope that these things can somehow come together and make cure and care a part of our responsibility as well as that of the medical profession. There we are, a somber subject this month, but one that we hope has a reassuring conclusion. That's all we have time for on Issues in Focus for this month. We'll see you next month.
Goodbye.